Great. This is a 60-year-old patient that really had profound ischemia of the left leg. Presented at Rutherford 2B. He was insensate in the foot, but he still had motor function left, and unfortunately had underlying cancer. And there really wasn't any other predictive risk factor that was identified in the patient. But on his non-invasive study, you can see his ankle brachial index is 0, his toe pressure is 0, and he's in big trouble with that left leg. Angiographically, on the next slide, you'll see that the iliac segment was open. There was a little filling defect in the mid-right superficial femoral artery, which was asymptomatic, but he also had some debris way down in the ankle in the right leg too, that implies that maybe this was an embolic event. On the left leg, the descending branch of the profunda femoral artery did not look normal distally. The popliteal artery was occluded, at least angiographically initially, but then once you just kind of waited out the contrast stream, you could see the big filling defect in the distal SFA, and the popliteal artery had additional clot in it as well. And once again, it's very hard to image the tibial arteries with contrast injected at the level of the groin. You really need to get down below the knee to understand what's open and what isn't. But all his tibial arteries also were involved with thrombus, except the posterior tibial artery. The next slide, several passes were made of the popliteal artery, and there was some residual clot in the popliteal artery, but reestablished flow. The patient's sensation of the foot improved initially at the time of just opening up the popliteal artery, which is what you'd expect. But then you're left with this myriad of tibial clot. I'm so glad Joe showed his initial case in which, after a couple of days of lysis, he just went ahead and put the device down into all the tibial arteries. This was very early on, and I just wasn't really eager to put the Pounce device either through the anterior tibial artery, through that curve, or down into the very distal portion of the posterior tibial artery, the perineal artery. So I elected to give the patient thrombolytic therapy. And clinically, the patient did just fine. But I think I've subsequently learned that I'm less hesitant to put the catheter into the tibial arteries. I'm less hesitant to go retrieve the distal clot at the time of the initial procedure and try to reestablish direct inline flow to the foot from the get-go. I know that the tibial arteries will look undersized with poor initial inflow perfusion, but the catheter and the markers on the catheter kind of help you, and the resistance to retrieving the catheter is something you kind of get used to the feel as it's coming back, and that kind of gives you a comfort zone, if you will. And I think that's something that I've learned with time is what is my comfort zone of what the force it takes to retrieve the catheters and all. As long as it feels normal, I don't have any qualms about putting it down in the tibial arteries. But this is one in which I did use subsequent thrombolysis, and it cleaned up adequately to the point where the patient was did actually quite well with it. On the next slide, it's just kind of an example, cleaning the vasculates again, and what subsequent workup was with the patient, and sometimes the funnel catheter itself, it says Trump there, but sometimes the funnel thing itself sometimes will deform, sometimes it will compress on itself because it doesn't have a lot of longitudinal axis integrity, but it aligns to the vessel wall quite nicely, and it's very easy to use. The next slide just has a real brief summary of a few observations through a few cases, and I'm not very concerned about whether the patient is a Rutherford in acute, chronic, acute, limb ischemia category or chronic limb ischemia category. If I can pass a wire down through it easy, I'm going to pull that clot out. If I've got an occlusion and a straight glide wire goes down nice and easy, I'm going to assume there's clot there and I'm going to pull it out. And the longer the occlusion, the more passes it's going to take to resolve that occlusion. And I'll usually clean out the proximal portion of the clot to begin with, and then one of the later passes then uncork the distal aspect of it, just to protect against distal embolization, which I think is intuitively concerning, but yet I don't think has been a big deal. The basket wire is very robust, so if you get some spill out into the sheath, it's easy to remove, flush, and put back in again if you need to. And I think in our experience, as our comfort level increases with putting it into slightly tortuous arteries, particularly the tibial arteries and then the smaller vessels, I think the use of lytic therapy is going to be fairly rare, or at least much less uncommon. It's going to be only for the very unusual case in which I think lytic therapy is going to be necessary. So just a few observations on a handful of cases.
Well, Bruce, that's great points. And I think that last one, where you're doing most of it in outpatient setting, but you're avoiding lytics, you're avoiding ICU stay, costs of drugs. I mean, this day and age when we've got to hospitals are losing money left and right. And, patients are in the hospital left and right. And, trying to show value that you're not using expensive medication, you're not using ancillary stents to plug stuff up against the side, you're not doing unnecessary surgeries, that you can get this done for the vast majority of these cases with one device in a very fast and efficient way, and that the staff can understand, I think, is where these values are really going. And I mean, that was the purpose I had when I developed it. I wanted it for me and for you guys. I wanted it to make my life easier. I mean, that's why I did the Ansel sheet. It was like we had complexity that needed to be made easier. And it wasn't because I wanted to work harder. It's because I wanted to work less. And, I wanted to get home, faster and those kind of things. So these are great slides, great cases, great summaries.